Hello, everyone, wherever you're joining us from today. Thank you for being here and for continuing to be part of this global community. After a month break, we're coming together again because knowledge matters. Today's session will focus on an update on clinical trials and approach at MSK. This session will give us a closer look at the MSK approach, helping us better understand how clinical trials are developed, how decisions are being made, and how ongoing research continues to move the field forward. We'll also hear about what is currently available at MSK, as well as any results or insight that they can already share. For families, this knowledge is a powerful tool, helping us ask informed questions and navigate complex decisions with greater confidence. Before we begin, I'd like to share a quick update. Unfortunately, Dr. Kushner was unable to join us today due to a schedule conflict. We're grateful that Dr. Wei has kindly stepped in to join us, and we truly appreciate her flexibility and willingness to be here with us today. Please feel free to ask questions in the chat, and Dr. Wei will address them at the end of the sessions. Dr. Wei, thank you again, and we look forward for your presentation and for learning together.
Thank you for inviting me for this talk. I'm sorry for people who comes here for Dr. Kushner. Unfortunately, he's not able to give the talk, but this is my great pleasure to share updates on MSK neuroblastoma treatment programs. And I think I can start. Shall I share my slides?
Yes, please.
Okay. Just want to confirm that you can see the slides. Okay, today I'm going to talk about MSK approach to improve outcome and reduce toxicity for neuroblastoma. Sorry. First, I have no conflict interest to disclosure. However, I'll be discussing non-FDA approved indications during my presentation. In terms of agenda today, I'll give an outline of MSK approach to neuroblastoma, including our strategies in treating local regional neuroblastoma without MEK amplification, and our standard program for high-risk neuroblastoma. Then I will focus our approach for relapsed neuroblastoma and what we have been done in the trial in the past and what we are currently working on. Neuroblastoma is one of the most common solid tumors outside the brain in children, and it is a tumor from immature cells of the sympathetic nervous system. And the sympathetic nervous system is primarily located along the spine from the skull base to the tailbone in the pelvis, with extension to the adrenal gland. So neuroblastoma sounds like one type of tumor. Actually, it is a tumor with big heterogeneity. And some kids may present with only local regional tumor without metastasis, despite that the primary tumor is very sizable. And for about 50% of kids, they present with widespread metastasis in bone marrow, soft tissues like lymph nodes, liver, lungs, at the time of diagnosis. And because neuroblastoma, it has such a big heterogeneity and every child is different and is unique. And that is why we need to brainstorm to formulate a plan that might be the best for the child. And our guiding philosophy in treating neuroblastoma is to cure and to avoid side effects. The upfront treatment is assigned based on the risk groups of neuroblastoma. And the risk group of neuroblastoma is defined based on clinical and the tumor characteristics, which predict the chance of recurrence and metastasis. For example, the patient's age, stage, and any MEK amplifications. And MSK for local regional tumor without metastasis, without MEK amplification, our strategy is surgical resection if feasible and watchful observation. And for kids younger than 18 months. And even with widespread metastasis and diagnosis, we know that this group of kids that have very better outcomes with long-term survival more than 90%. So the strategy is to minimize toxic chemotherapy if possible. And for the rest of kids with neuroblastoma, they have high-risk disease, and which requires multimodal therapy to achieve the best cure. Even with our current multimodal strategies in treating high-risk neuroblastoma, the long-term cure is about 50 to 60%. First, I'm gonna briefly mention our approach for local regional neuroblastoma without metastasis, without mechanism amplification. So our protocol is called N0, which is no chemotherapy if the tumor can be resected upfront, or N-stop, which is if a patient receives chemotherapy before transfer care to us, then we'll stop chemotherapy after surgery. And this approach also apply to kids who have local renal tumor but are considered as a high risk. For example, some of the L2 tumor or tumor with prognostic markers, for example, unfavorable histology or chromosome abnormalities. And for kids with incomplete surgical resection who still have residual tumor left, we don't give chemotherapy, and we do watchful observation with scans. And for kids, surgery is too risky to be taking, for example, high risk of injury to nerves, vessels, and organs. Then, if the tumor does not cause any symptom, then we also recommend watchful observations. The theory or the rationale behind this strategy is because we know that this type of tumor has limited potential to metastasize or to proliferate after surgical resection. And some of these local regional tumors are quite refractory to chemotherapy or even high-dose chemotherapy. So giving chemotherapy to this subgroup of patients would not be beneficial. And also for kids who have regrowth or recur of the residual tumors post-op, the chance of cure is very high. So for this subgroup patients, that we try to minimize cytotoxic agents like chemotherapy if possible to achieve the cure, but with less long-term toxicity from chemotherapies. In contrary, to cure high-risk neuroblastoma, that we need treatment that target bulky and metastatic disease and diagnosis, and after they achieve complete remission, which is no evidence of disease by scans or in the bone marrow. And the next step is to eradicate any microscopic residual disease. And the first step is called induction, and the standard strategy for induction is include high dose intensive chemotherapy and surgical resection. So from the previous analysis, it has demonstrated that for the best cure can be achieved by giving dose intensive chemotherapy, which is a high dose chemotherapy given with short intervals. And this strategy can achieve the maximum tumor burden reduction and to avoid any resistance from the chemotherapy. And surgical resection is to resect the primary bulky tumor after a couple rounds of chemotherapy. And ideally, complete remission can be achieved after induction. However, the current induction rate is still suboptimal. And for kids who achieve complete remission, next step is for minimal residual disease, and the standard of care includes myeloablative chemotherapy, followed by autologous stem cell transplant, local radiation, anti-GD2 monoclonal antibody, and differentiation therapy with isotretinoin. At MSK, our current induction regimen is called N9. I'm going to talk about it later. And the surgery after 3 cycles of chemo and after complete remission is achieved, consolidation with immunotherapy and radiation. And after finishing immunotherapy, there's an option to participate in neuroblastoma vaccine trial. So why we generate a 9 induction regimen. So from our previous experience, we know that upfront dose escalation is very important. And in the past, we have given 7 cycles of chemotherapy, which has been gradually reduced to 5, and now to 4 cycles of chemo in the induction. What the rationale is that by increasing the cycles or the dosing, the cycle of chemotherapy to during the induction, it gains a slightly modest increase in response rate. However, it at the cost of substantial toxicities. And for example, about a quarter of patients developed hearing loss after 2 cycles of cisplatin. So we want to cure, but with less toxicity, not to mention the long-term toxicity for kids that survived neuroblastoma. So we also know that achieving complete remission after induction is such an important prognostic factor. However, our current chemo induction regimen is not it's still the response rate is still suboptimal. So we want to generate an induction regimen that preserve the anti-neuroblastoma efficacy but reduce toxicity. So we that leads to our I9 induction chemotherapy, which consists of 3 non-cross resistant regimens and total of 4 cycles of chemo, but kids can receive 1 cycle of chemotherapy in outside hospital before transfer care to us. And for this 4 cycle of chemo, it consists of 2 cycles of CTV, which is cyclophosphamide, topotecan, vincristine, and 1 cycle of ICE, which is ifosfamide, carboplatin, etoposide, and also CAV, which is cyclophosphamide, doxorubicin, vincristine. So the CTV and the ICE are those 2 chemo regimen have demonstrated very encouraging anti-neuroblastoma activities in relapsed and refractory neuroblastoma. That's why these 2 regimens have been added to our induction protocol, and with no cisplatin, that we propose less autotoxicity, and with only 1 cycle of doxorubicin, and there will be little mucositis. And by using novel induction regimens, and we hope that it will generate a better anti-neuroblastoma activity. So this N9 protocol was closed, and we treated 15 patients on the protocol and more patients as per the protocol induction regimen. No unexpected adverse events observed, and we were able to collect the target number of stem cells. It suggests that this novel induction regimen does not affect the ability to collect stem cells for future use. And all of the patients and 9 had gross total resection of the primary tumor. So this also support that this novel induction regimen does not affect the resectability of the primary tumor. And the 4 kids on the N9 trial, none of them had a hearing loss. In terms of response to induction, there were 6 CR, 5 PR, and 4 stable DDs, but we are not disappointed by this number. From our experience, we know that for kids who still had residual DDs, they were likely to be cleared by immunotherapy. So of the 9 patients with residual DDs post-induction, 7 of them achieved a CR, and 1 metabolic CR, which means no tumor activity by FDG PET. So that pilot N9 induction regimen led to our current induction trial, which is called N10. So the N10 is to evaluate if adding 2 cycles immunotherapy will increase the response rate, but we do it in an adaptive approach. We already know that a subset of patients will not respond to chemotherapy, and those patients do not deserve to be exposed to ongoing chemotherapy. And based on our previous experience with naxitamab and kids with primary refractory disease in bone and bone marrow, then the tumor responds to naxitamab. So these kids will receive naxitamab, and for kids who have a complete response to chemotherapy, they also do not deserve further chemotherapy, including transplant. So the minimal residual disease can be eradicated by immunotherapy with naxitamab. And for the rest of patients, they have a good but not complete response to chemotherapy, and this patient may benefit from chemotherapy plus immunotherapy. So our intent is to test this hypothesis. As I mentioned, after 4 cycles of chemotherapy plus surgery, if patient only have stable disease in bone and bone marrows, and then they will receive 2 more cycles of naxitamab with GM-CSF before end of induction disease evaluation. And for kids with disease in soft tissue, and they will receive chemoimmunotherapy because naxitamab has very little impact on soft tissue. And for kids who achieve partial remission post-induction, and those children will receive 2 cycles of chemoimmunotherapy with naxitamab, irinotecan, temozolomide. And for kids who have a complete response to induction regimen, and then we'll go proceed with 2 more cycles, with 2 cycles of naxitamab before disease evaluation. So now we have treated 13 patients and 10, however, we don't have any preliminary data. That is our current induction regimen. So the goal is to achieve complete remission. So once complete remission is achieved, and then we will, the next step is to irradiate minimal residual disease and MSK, that we give local radiation and anti-GD2 monoclonal antibody for this purpose. At MSK, we don't give mega chemotherapy with autologous stem cell transplant. This is based on our analysis, and transplant was auto transplant was a major feature of MSK neuroblastoma program in the past, but we stopped doing myeloablative chemotherapy with transplant in 2003. Because in the past, we were able to treat a large number of patients with mouse version of naxitamab, and this large amount of patients allowed us to perform very robust statistical analysis, that we found out there's no long-term survival benefit of doing transplant. And we also believe for some of the tumor cells that survived through induction chemotherapy, they are likely to be chemorefractory by giving high-dose chemo in the auto transplant or changing chemo regimen. They are unlikely to eradicate those chemorefractory tumor cells. So that's why we would rather to use different strategy like immunotherapy to eradicate those chemorefractory neuroblastoma tumor cells that are still left after induction. And of course, the toxicity, including long-term and short-term toxicity of auto transplant, are substantial. Some of the short-term acute toxicity, for example, in the liver, in the kidneys, can delay the subsequent immunotherapies. That's why we have stopped doing transplant in our patients. But of course, this is a single institute experience analysis. It does not have the power to change the standard practice, and hopefully in the future there will be no transplant strategy will be tested in a large population on a trial basis in the immunotherapy era. So to eradicate residual cells in the surgical primary tumor site after surgery, that radiation is a very effective way to do so. And MSK, we give radiation after first cycle of immunotherapy versus elsewhere before starting immunotherapy. This will allow us to give immunotherapy as soon as they finish induction. And then we're able to give 2 cycles of immunotherapy and radiation in between those 2 cycles in like 4 to 5 weeks. And we give radiation to the primary tumor site and also sites worrisome for relapse, for example, sites with persistent MIBG positivity or bulky lesions and diagnosis, for example, a big skull lesion and diagnosis. At MSK, we give hyperfractionated RT radiation. Hyperfractionated means that we give a smaller dose, but divide the doses into multiple doses. So instead of doing daily fraction, that we do 2 fractions a day, couple hours apart. This can, in preclinical study, this strategy shows that it causes less toxicity to healthy tissues in the radiation field. And over the past years, and Dr. Suzanne Walden, who is our radiation oncologist team, has been studying reducing the dose of radiation in kids with neuroblastoma after gross total resection. So the standard radiation dose is 21 gray. In the past, we reduced the dose to 18 gray and did not observe any local recurrence. And now the dosing has been further reduced to 15 gray, and we treated more than 50 patients with 15 gray, and the total local failure rate for kids received reduced dose of radiation is about 4%, which is comparable to the rate with standard dosing 21 gray. So if 21 gray is effective while we reducing the dose, is to mainly is to prevent toxicity to the from the radiation. For example, a lot of kids have tumor along the spine, and the vertebrae of the spine will be included in the radiation field. And those vertebrae, the spine is very important for adult height. So by reducing radiation, that it can facilitate a better growth of those vertebrae and can achieve a better adult height. Of course, less radiation will help to prevent other long-term toxicities or side effects, complications, for example, secondary tumors and like endocrine issues, for example, diabetes. And then we use anti-GD2 monoclonal antibody to eradicate, systemically eradicate any residual tumors. The anti-GD2 monoclonal antibody has changed the landscape of treating high-risk neuroblastoma. And GD2 is a lipid sugar antigen highly expressed on neuroblastoma. And there are many strategies in targeting this antigen on neuroblastoma cells, including monoclonal antibodies, vaccines, and CAR-Ts. By far, there are 3 anti-GD2 monoclonal antibodies approved by FDA or EMA, including dinutuximab beta, and naxitamab. And when this antibody bind with neuroblastoma cells, it can recruit immune effector cells, for example, neutrophils, macrophage, lymphocyte, and can activate those immune cells and generate tumor death. At MSK, we use naxitamab for refractory bone and bone marrow disease, which is a FDA-approved indication in neuroblastoma. And we also use it to consolidate remissions, including first and more than first remissions. We also use naxitamab in combination with chemotherapies to treat relapse and refractory neuroblastoma. As I previously said, after induction chemotherapy, there's still about 50 or even more percent of patients still have residual disease left. So how to we eradicate those how to eradicate those refractory disease. Nowadays, immunotherapy or chemoimmunotherapy have been used. At MSK, we treated 32 patients with naxitamab plus stepped-up dosing of GM-CSF on phase 1-2 clinical trials. All those 32 patients had primary refractory bone and bone marrow disease after induction chemo. 22 of those patients completed the protocol without progression of disease. 18 of those received the vaccine. Complete response was observed in 75% of those patients, and major responses were even observed in patients with high cure scores up to 25. So this clinical trial data demonstrate that naxitamab with GM-CSF alone without chemotherapy is a good option for primary refractory disease in the bone and bone marrow. Then the other option is to combine immunotherapy with chemotherapy. At MSK, we also use naxitamab with irinotecan, temozolomide, and GM-CSF, which is called a HITS regimen. The HITS regimen is a 2-week treatment. The chemo is given during the first week, and 2 doses of naxitamab is also given during the first week. And GM-CSF is given during the second week, and 2 more doses naxitamab is given during the second week. So compared to other chemoimmunotherapy, we use a higher dose of temozolomide and antibody, and naxitamab is given during chemotherapy and after chemotherapy, concurrently with GM-CSF. This regimen has been tested on a phase 2 trial, and 90 patients were treated with HITS, and 8 of those patients had primary refractory disease. Objective response was observed in all of these 8 patients. And the majority of those patients had relapsed disease, but the objective response was 61%. In the entire cohort, the RNA response was 30%, which is comparable to other chemoimmunotherapy regimens using different monoclonal antibodies. Of note, the objective response was also observed in soft tissue, which is a compartment hard for immunotherapy alone to generate any anti-tumor effect. And for patients who previously treated with each component of this regimen, for example, naxitamab, irinotecan, temozolomide, or donataximab, irinotecan, temozolomide, objective response were also observed. So our experience of HITS regimen, now our HITS regimen has some modifications that we include a higher dose of GM-CSF and also extension of the GM-CSF into 2 more days after the last dose of naxitamab. Our experience has also been replicated by Dr. Mora's group in Barcelona. He treated 34 patients with primary refractory neuroblastoma post-induction. The major response rate was 30% among those patients. And he also observed that for patients who received HITS soon after induction, the survival rate is much higher than those who received HITS regimen after receiving other post-induction treatment, including chemotherapy, immunotherapy, or other type of treatment. So this indicates earlier use may provide more benefits. Then after achieving complete remission, naxitamab is also a good option to consolidate first remission. 59 patients were treated with naxitamab plus GM-CSF in their first remission on our phase 2. Of those 59 patients, 46 patients received a vaccine after completion of immunotherapy. The 3-year event-free survival from the first cycle of naxitamab were 73%, and 3-year overall survival was 97%. The rate is similar to the rate with other different antibodies. 19%, which is 11 patients, received the transplant, but majority of the patients did not receive the autologous stem cell transplant. And we found out prior transplant was not prognostic for patient survival. And in a different separate retrospective analysis, and we analyzed the survival of patients who received naxitamab with GM-CSF plus vaccine, but without transplant in their first complete remission. And 43 patients were included in this analysis, and 34 of those patients received the vaccine. And the 3-year event-free survival was very encouraging, which was 80% from their first cycle of naxitamab treatment, and 3-year overall survival was 95%. So the outcome is as good or slightly better than the naxitamab with original schedule of GM-CSF. So our original schedule of GM-CSF is to start GM-CSF injection on the same day of naxitamab. And now we are doing step-up dosing, which to start GM-CSF at lower dose a couple of days before naxitamab, and start full dose on the first day of naxitamab treatment. The purpose is to prime or get the immune system ready for naxitamab treatment. But of course, this is a retrospective study. It's very, very hard to tease out the exact cause for this better survival outcomes. And from the previous two analysis, patient received different induction regimens, including the COG induction, MSK induction, and rapid Kojak. Then in a separate analysis that we analyzed, kids who received the European induction regimen, rapid Kojak, and went to post-induction treatment and immunotherapy without autologous stem cell transplant. So there were a total of 28 patients. 10 of those patients achieved complete remission post rapid Kojak induction, and all of those kids stayed in complete remission after finishing immunotherapy, and all of them stayed in complete remission 3 to 4 years, 4 years follow-up. And 18 of those patients had primary refractory disease, and among those 18 patients, the 3-year event-free survival rate was 62%. Overall survival rate was 95%. So this outcome is similar to kids who received rapid Kojak plus autologous stem cell transplant and immunotherapy. So this study indicate that avoiding myeloablative chemotherapy and autologous stem cell transplant does not appear to affect the outcome of this patient who received rapid Kojak. And then naxitamab treatment, I think one of the challenging is managing the acute and intense side effects. At MSK, we have been generating strategies in mitigating those side effects. We use ketamine for patients who had significant pain from naxitamab treatment, and the ketamine infusion during naxitamab treatment really improve the pain and makes the treatment much more tolerable. We also pre-medication with methadone, which is a long-acting pain medication that can provide a longer duration of coverage post naxitamab treatment. And for kids who developed refractory hives, then we use omalizumab to help them prevent the side effect and or reduce the severity. Profound hypotension and other symptomatic side effects can occur after naxitamab or during or after naxitamab treatment. The step-up method can decrease the severity and also prevent this type of reaction. The step-up method is to initiate naxitamab infusions at very low rate and increase it slowly. The purpose is to desensitize, which is to get the nervous system adapted to naxitamab treatment. By doing this, it can make the treatment, this type of side effects much more manageable, and then can enable kids to continue receiving naxitamab treatment. Now, naxitamab has been used more and more nationally and internationally. I think strategies in reducing those side effects will continue arise. And then this is just a quick summary of MSK high-risk neuroblastoma treatment program, which includes 4 cycles of chemotherapy, but patient can get, before coming to the Int'l trial, patient can get one cycle of chemotherapy. And no transplant, no cisplatin, that we use immunotherapy and radiation for minimal residual disease, and patient has the option to participate in the vaccine trial after completion of the high-risk neuroblastoma treatment. By this high-risk program preserve the anti-neuroblastoma efficacy at the long-term outcomes, but not generating, but preventing and also reducing the long-term side effects, including hearing loss, fertility issues, and endocrinology issues, secondary tumors, and a better linear growth from reduced dose radiation. Next part, I'm going to talk about our strategy in managing relapsed neuroblastoma. The relapsed neuroblastoma is even more challenging, and a lot of factors need to be taken into consideration. For example, the pattern of relapse, the site of relapse, and the extent of relapse and patient's previous treatment. There's no standard consensus or standard care for relapsed neuroblastoma. Our fundamental philosophy for relapsed neuroblastoma is that many patients with relapsed neuroblastoma can be salvaged, and they will benefit from available therapies. So the first step for relapsed neuroblastoma is to achieve a second remission, and the medication used are considered a salvage treatment. And as I say, there's no consensus of what type of salvage treatment should be used. And for focal relapses, they tend to have a better outcome. And those focal relapses, for example, the isolated bone or soft tissue, can be managed by focal therapies, for example, surgeries or radiation. For disseminated relapse, they tend to have worse outcome, and systemic treatment are warranted. For example, chemoimmunotherapy or second-line chemotherapy, MIBG therapy, or target therapy based on the genomic features of the tumor. And CNS relapse is another challenging relapse to salvage. I'm going to talk about our MSK experience about CNS relapse. So once second remission is achieved, there is still no consensus or standard on how to consolidate this second remission. At MSK, our approach is to give more immunotherapy with GM-CSF, and there's also option of receiving bivalent anti-neuroblastoma vaccine. Nowadays, chemoimmunotherapy has been considered as upfront treatment, salvage treatment for relapses. At MSK, we also use naxitamab or dinutuximab plus chemotherapy regimen, for example, irinotecan temozolomide, low-dose cyclophosphamide topotecan. And for some patients, salvage chemotherapy can also be considered. For example, if patient had chemo-sensitive tumor and diagnosis and have not received any chemotherapy for years. So the chemotherapy that can be that are used at MSK include like irinotecan temozolomide or high-dose regimens, for example, ICE, cyclophosphamide, topotecan, vincristine, and some of those regimens are better for CNS relapse. And after a second remission is achieved, naxitamab is a good option to consolidate the second remission. In the previous phase 2 trial that we evaluated 60 patients survival after receiving naxitamab as consolidation regimen for their second or later complete remissions. 18 of those patients had more than 2 prior relapses. And of those 60 patients, 42 patients were in CR post this trial, and 34 of them received the vaccine. And the 5-year event-free survival is also very promising, which is 50%, and the 5-year overall survival was 68%. About half of those patients received autologous stem cell transplant before their relapse for their high-risk neuroblastoma after high-risk neuroblastoma diagnosis, but all of these patients did not get any auto transplant or allogenic transplant or salvage regimen. The outcome is slightly better than that with a mouse version of 3F8 and GM-CSF. But of course, it's hard to tease out where the benefits coming from. It could be from naxitamab, a better version of this type of antibody, or it could be from the vaccine. I'm going to talk about vaccine trial in a bit. Then the CNS neuroblastoma relapse is challenging. It's because It's rare. It's about 5 to 10% of kids will have relapse in the brain or the spine, and the location of this relapse is in very critical organs, and there is blood. There's a barrier between blood and the brain. A lot of medications cannot penetrate into the CNS, such as immunotherapy, dinutuximab, naxitamab. So the salvage regimen of CNS relapse also depends on the severity of this relapse, and if adding concurrent actual brain relapses, like relapses in the bone or bone marrow or soft tissue outside the brain, or how many lesions in the brain. But our approach is that if the tumor is resectable, then we recommend surgical resection to achieve a rapid tumor reduction. And chemotherapy can be considered, which is a systemic chemotherapy given from into the blood. And some regimens have better brain penetration, for example, irinotecan, temozolomide, carboplatin, or ICE regimen. We also recommend cranial-spinal irradiation for kids with CNS relapse. And from the retrospective analysis, for kids who only received focal radiation to the brain lesion, almost all of them had a further recurrence in the CNS. And the majority of the survivors from CNS relapse are the kids who received cranial-spinal irradiation. And the cranial-spinal irradiation is to give radiation to the whole brain and the spine. This can help to eliminate any residual tumor cells more completely in the CNS system. But of course, it will have long-term impairment. However, we have been reducing the dose. Now we have the standards more like 18 gray, and then the dose can be further reduced for infant. And for kids who have concurrent systemic relapse, and or for kids who are at risk for systemic relapse, immunotherapy can also be considered. And besides those above strategies, we have been giving chemotherapy or radio-labeled immunotherapy into the brain ventricles directly. So the device enables us to give treatment directly into the ventricles is called Omaya, and it is like a Mediport, and the Omaya is underneath the skin of the skull, and there's a catheter connecting the reservoir with the ventricles of the brain. So, and then the medication can be given by injection into the Omaya reservoir, and it can be delivered into the brain, circulating in the fluid surrounding the brain and the spine. We have been giving chemotherapies through Omaya. So this will allow us to give multiple and repetitive chemotherapy into the ventricles directly, instead of giving high-dose chemotherapy from the blood, which generates more toxicity to the bone marrow. And the other novel strategy is which is radio immunotherapy. And in the past, we injected iodine-labeled obinutuzumab or iodine-labeled 388. And the theory behind this is that obinutuzumab is a monoclonal antibody targeting B7H3. So B7H3 is also neuroblastoma target. It is highly expressed on neuroblastoma. And in the laboratory, and the FedEx label the monoclonal antibody with a radioisotope, which carry the radiation. And after injecting the whole radio-labeled monoclonal antibody into the ventricles directly, and this antibody can recognize the tumor cells and can deliver the radiation specifically to the tumor cells. And the advantage of this strategy is that it can deliver high dose of radiation, also avoid damage to surrounding healthy brain tissues. Dr. Kramer has conducted clinical trial examining this strategy in treating CNS neuroblastoma. And from this imaging that we can tell after injection of albuterol, like iodine level, which is different, which is an isotope, and it can achieve most of the medications circulating in the brain and the spine. Only minimal amount of radiation goes into the other organs or into the liver. So this allows us to give high dose of radiation to the tumor and also minimize toxicity to other organs. But of course, because this type of treatment is aiming microscopic residual disease, because this type of radiation is not very strong, and it can and the duration of the radiation is short range. And as I said, the advantage is that it will avoid damage to the surrounding tissue, but it's also it may not be very effective against bulky tumors. So that's why we give this type of medication post surgical resection and the radiation. And from our previous clinical trials for kids who received this novel regimen had much better long-term survivals, which is like 40 to 50% compared to less than 10% from the historical data. And currently we are developing a new protocol, but using a better version of albuterol. So we replaced the iodine with 177 lutetium. So the lutetium does not cause any toxicity to thyroid, and the radiation is also short-ranged, so it will not cause significant toxicity to surrounding healthy brain tissues. And hopefully they will have this trial open in a couple months, and the trial will be open to kids with primary refractory or relapsed primary brain tumors or metastasis of solid tumors into the brain. And Dr. Falksek will be the PI, and I will be the co-PI responsible for patients with CNS neuroblastoma relapse. And then after finishing all the salvage treatment or after finishing the treatment for high-risk neuroblastoma without any history of relapse, bivalent vaccine is an option to maintain this remission. So vaccine is one type of immunotherapy. Instead of giving monoclonal antibody into our blood directly, the vaccine can stimulate immune system to make antibodies their own. So as I previously said, GD2, GD3 is a lipid glucose, like sugar lipid. So itself does not generate a good immune response. And so this vaccine, GD2, GD3 is combined with vaccine adjuvant, which are proteins that can help our immune cells to recognize GD2, GD3. And by giving the vaccine injection itself also does not mediate robust immune response, but we have found out if beta-glucan was given concurrently with vaccine, it will boost a higher immune response. So beta-glucan is a soluble fiber, and it can be found in yeast, fungus, or cereals, and it is a liquid taken by mouth. And so with the help of beta-glucan, this vaccine can elicit response, and then immune cells like lymphocytes can make anti-GD2, GD3 antibodies. And if there are any tumor cells left, and the GD2, GD3 can recognize the tumor cell and lead to cell death. So in the previous phase 1 trial, vaccine and beta-glucan were very well tolerated, and immune response were observed. And in the subsequent phase 2, that we treated more than 100 kids in second or more than second remission, and with bivalent vaccine. All of the kids had a history of relapse in the past. Then we observed that despite prior relapses, durable remission was possible after vaccine. And the 5-year event-free survival was 32%, which is better than historical data. And the efficacy of the vaccine is hard to evaluate because all the kids started vaccine no evidence of disease stats. So there's no tumor by the skin or in the bone marrow. So it's very hard to direct evaluate response of the tumor to vaccine. However, we observe that for kids who generate a good response to vaccine, which is measured by the amount of anti-GD2 antibody that they make after receiving vaccine, we found that for kids who generate more antibody on their own, they have a better survival rate, a less chance of recurrence. And in the following phase 2, then we tested the timing of beta-glucan given earlier versus late. So one group patients received beta-glucan and the first vaccine injection, and the other group patients received beta-glucan after third injection and before the fourth injection. Then we observed that for kids who received beta-glucan with the first injection generated higher level of anti-GD2 antibody. And again, we also observed for kids who generated higher antibody, they had a better progression-free survival. So this might suggest the vaccine works if they can generate a good response to vaccine. So that lead to our current vaccine trial, which is open to kids in remission and without any history of relapses. And our primary question is if adding GM-CSF will further increase the response to vaccine. And there are two groups of patients. One group of patients will receive the standard vaccine with beta-glucan, and the other group of patients will receive standard vaccine with beta-glucan and GM-CSF. Now we treated more than 770 patients on each arm, and there are also kids who receive standard vaccine for a variety of reasons. For example, allergy to GM-CSF, or international patients, or patients who had relapsed on previous vaccine, but they are undergoing revaccination. So on this, our current vaccine trial, we have treated more than 200 patients, but we don't have any interim data available at this moment. Hopefully, when we finish accruing, and we will have some information on if GM-CSF will make the vaccine work even better. And then that will be the next. I will talk about our future perspectives. I think we'll stick with our philosophy, which is to cure with less toxicity. So we need a better scan, better testing, and better salvage therapy for relapsed or refractory neuroblastoma. I believe Dr. Modak talked about MFBG recently. So, MFBG is using fluorine instead of iodine for the neuroblastoma scan. So it is less torture for kids. It is a 1-day imaging, and the imaging itself is much shorter, and also it provides better quality of imaging. It can also detect more lesions that proved to be true lesions in our previous phase 2 studies. And the results and analysis of phase 3 awaited before consideration of approval. But of course, the application of MFBG in diagnosing and guiding neuroblastoma treatments need to be further refined in large patient population. Then we also need a better testing for neuroblastoma, which is less invasive than biopsy and also sensitive. So circulating tumor DNA, the ctDNA is DNA fragment from the tumor that is released into the blood. So it can be detected from the blood, and the ctDNA has emerged as a dynamic biomarker for in cancer. In clinic, we use it routinely to help us monitor disease progression, response to treatment, and to provide more information on the genomic profile on relapsed or refractory neuroblastoma. In particular, some tumors are not one biopsy is not amenable. And more importantly, because this is a very sensitive test, we want to test if we can use it for minimal residual disease detection. And currently, our instructor, Dr. Richard Hughes, has been studying using a more sensitive type of ctDNA in detecting minimal residual disease. So we profiled the primary tumor and diagnosis, and using that genomic information to generate a customized, personalized tumor-informed testing for individual tumors that can be used as a biomarker to detect minimal residual disease. Now we're currently testing this strategy in the samples in patients receiving vaccine, because we know that for patients who started on the vaccine trial, they don't have any evidence of tumors by scans or by bone marrow examinations, so that we can correlate this ctDNA with our scan findings, and also correlate the MRD results with the relapse events. So why it is important to detect a minimal residual disease is because it can help us to further identify kids who may benefit from more treatment, and also reduce treatment for kids who have no evidence of disease by very sensitive testing. And then that will, besides sensitive scans or sensitive testings, we also need a better effective salvage treatment. So one novel strategy has been pioneered by Dr. Chang is called SADA, which is a two-step pre-targeted radioimmunotherapy. So in the past or currently, we have been giving radio-labeled immunotherapy at the same time. So this antibody carries radiation, and after injection of this medication, the concentration of the medication as well as the radiation dose peaked in the blood, and some of the antibody will bind to the tumor. And however, because the dose of a significant amount of radiation in the blood, it will generate significant toxicities, for example, myelosuppression, which may necessitate stem cell infusion. This will not allow us to give a high amount of radiation safely. And this two-step strategy is to separate these two components and give antibody first. And this antibody does not have any anti-tumor effect. So, and after injection of this antibody, the antibody can combine with the tumor and also give the body some time to declare the antibody from the blood system. And there will be most of the antibody will be binding to the tumor, but not circulating in the blood. And a couple of days later, for example, 2 days later, then we inject radioisotopes. And this radioisotope is designed to recognize the antibody. So after injection of this radioisotope can recognize the antibody binding on the tumor and deliver radiation specifically to the tumor. Because on day 2 or day 3, when the isotopes was injected, and there is a minimal amount of antibody in the blood, so they will have a minimal toxicity to the bone marrows or a kidney or other vital organs. So this strategy will allow us to give high radiations and also to avoid toxicity. And this amount of radiation cannot be given with one-step strategy. So in preclinical experiments, and after 3 radioisotope injections, there was no tumor growth in the mice carrying neuroblastoma tumors. And because it is a very novel strategy, we're currently designing the clinical trial carefully, and hopefully that we can have it open in the near future. And this will be the end of my talk. At MSK, we have a dedicated team taking care of neuroblastoma kids with neuroblastoma, and including nurse practitioners, nurses, research nurses, and physicians. and also our wonderful coordinators and people in the lab. But I also want to thank for our patients and their families for trusting us in taking care of their children. And again, I would like to thank for this organizing this talk. Now, okay, this is the end of my talk. I will answer the questions. So I think I need to stop share. Okay. Okay. The first question, is there a difference between anti-GD2, naxitamab, or dinutuximab beta? Setting for children who have already got one of those two prior to relapse refractory? That is a very good question. So in terms of those different anti-GD2 monoclonal antibodies, there's no clinical trial comparing the efficacy of those antibodies to see which one is better. And for kids who have already received one of those antibodies upfront and who unfortunately relapsed, even using the same type of antibody like dinutuximab and then and relapse, and then dinutuximab is again used for relapse disease, response rate is still observed, which is about 30 to 40%. So we don't know if alternating those antibodies will generate a better response rate. At MSK, we in some kids, if they relapsed on one type of antibody, we may consider to switching the antibody to a different one. For example, if kids relapse on naxitamab, or if kids progress on naxitamab, we may consider to change the antibody to different one, for example, dinutuximab. But of course, there's no data to support this type of strategy, so we don't know if changing the antibody will provide more benefits. So hopefully we can analyze our own data because we have treated many patients with two antibodies. But in the US, we don't have any experience with dinutuximab beta, but at MSK, we use both naxitamab and dinutuximab. Sometimes we have to alternate those two. And I think we are planning to analyzing like the outcomes of alternating or switching one from one antibody to the other one, but to be honest, we don't know if it will provide actual benefits. Next question is, regarding kids who have had multiple relapses and his treatment, does creating naive GD2 antibodies have any downside? In other words, are there healthy cells which have GD2 receptors and are affected by doing his or getting the vaccine? Let me see if I understand it right. Native GD2, okay. So that's a very good question, because for kids who had multiple relapses and already received the treatment with anti-GD2 monoclonal antibodies, it's possible the neuroblastoma cells or cells that thrive through immunotherapy may already downregulate GD2 or stop expressing GD2. I think one medication or the vaccine definitely cannot work for every kids. But from our previous analysis or from the experience with immunotherapy, for example, for kids who received dinutuximab or naxitamab after diagnosis of neuroblastoma, and before their relapse and after relapse, they still respond to the same antibody, or they still respond to anti-GD2 monoclonal antibody. So I think those are still a good option to consolidate. But of course, you have the option to try different strategy. For example, DFMO for maintenance, which does not depend on GD2 or GD3, or different medications. Example for kids who have ALK altered tumors at relapse, and lorlatinib is a very viable option instead of doing vaccine. Okay. And next question is about the phase 2 study of naxitamab plus step dosing GM-CSF for patients with high-risk neuroblastoma in second or later complete remission. Okay. And then there is a patient who, I didn't mention this, for patient who had prior exposure to naxitamab tend to do worse with naxitamab treatment as in their second complete remission. I think I don't have a good explanation. I think it's possible because as it mentioned in the QA, because of the heterogeneity, and then for kids who have already received naxitamab, and some of the tumor cells may already generate resistance to naxitamab. That's why using the same immunotherapy reagent may not provide the best protective effect. And I think for relapse and refractory neuroblastoma, there is, compared to newly diagnosed neuroblastoma, the chance of downregulation of GD2 is higher than, and this is a mechanism how those neuroblastoma survive through immunotherapy, or other mechanism like tumor microenvironment can also contribute to the resistance. So I think to be honest, I don't have a good explanation. I think it's because it's just like a lot of the biology, in particular for relapsed tumors, are still unknown and then need further exploration. So the next question is about MFPG. The MFPG production is simpler than the IDAN. Well, it allows countries where there is no MFPG to be able to access disease monitoring by MFPG. So you think that could become available? Yes, I do agree. I think MFPG practically it's a better. The fluorine is better radio tracer, and which is easier than the 123 IDAN, and it will definitely provide more access to like MFPG scanning in countries that with limited resources of the 123 IDAN, and make it more disease evaluation even more accessible than MIBG. So I think that is very, very possible. And I think that is the case of MFBG in China. In China now, they're using more and more MFBG because it's more available compared to MIBG. Okay, and then the the other question is about radioimmunostudy about GD2 SADA. What can be the preclinical mouse work is very impressive. When can this be expected in human trials, and do we expect similar results in the clinic? So we're still discussing about the design of this trial because this two-step strategy and this even more complex than other new type of drugs like immunotherapy, and also there are a lot of more than one variables like the antibody itself and the radioisotopes, and also the time interval between those. And we also want to develop a good trial that will provide therapeutic benefit even for kids who start at the lowest dose. So I hopefully it can be open soon because MSK has the drug, and once we have a very valid and reliable design, and I think it's possible that we can have it open hopefully in next couple of years. But I don't have an exact timeline for the trial. And but preclinical data is impressive. That is because those tumors cannot completely mimic refractory or relapsed tumor in human, and those mouse tumor, they are injected underneath the skin. So, and but on the preclinical study, I agree it's very impressive. Even after 2 injections of such medications, there is no tumor growth, even for long term, like for a year, and their progression-free survival is beneficial. I think one thing we have to keep in mind is the heterogeneity of relapse and refractory tumor, and this GD2 SADA also targets GD2. So if the tumor uniformly express GD2, and it's a good strategy because we know that neuroblastoma is very sensitive to radiation. So this GD2 SADA can allow us to give very high dose of radiation that cannot be given by the other traditional way, for example, MIBG therapy. And the myelotoxicity will limit the amount of radiation that we can give. But this strategy can allow us to give high dose. But as I said, we wish it will generate a durable response, like more persistent suppression of the tumor. And the currently trial we're designing is still using 177 lutetium, which is beta particle from the radiation. So it's strong, but not that strong enough. Hopefully, once we prove this strategy is practical, is safe, and generate tumor response, that we can move on to replace the lutetium with stronger radiation, which is like alpha particle. So I think in that scenario, we would expect a more like prolonged duration of tumor suppression using strong radiation isotopes.
Dr. Wei, I think for time consideration, let's take the last question for the CAR
Sure.
T one, and we'll finish with that.
I didn't see the CAR T question. Oh, okay, I need to scroll down. The CAR T.
Yeah, the MSK perspective on CAR T approach.
Yeah, I think it's a reasonable option after relapse, in particular, if they have received antibodies like antibody treatment for upfront high risk neuroblastoma and relapses. It's just use of course it target the same antigen GD2, and but it use the same mechanism of cure, and then the effect of CAR T can be more persistent rather than giving antibody. So I think this is a good option. I think the CAR T work best if there is less tumor burden, and then the trial in Italy is very promising and encouraging. But MSK, we don't have G2 CAR or other type of TAR. Of course, we're developing our own CARs, but I think that is definitely one different type of strategy to provide longer duration of remission in kids with neuroblastoma. Do I support patient pursuing such treatment abroad? I think that's a very good question. Of course, I would recommend treatment that can achieve the best cure, and but a lot of realistic factors need to be taken into consideration, like the cost, traveling, and but if I would say if the case failed multiple lines of standard like treatment for high-risk neuroblastoma or for relapsed neuroblastoma, I think it's reasonable to consider a different strategy in getting them back into remission or prolong the remission.
Okay, I think we're for time consideration, let's finish with that. Dr. Wei, thank you so much for being here with us today and for sharing your time, your expertise, and your perspective. We truly appreciate your flexibility and your willingness to step in and lead this session in replace of Dr. Kushner. To everyone who joined us, thank you. Your questions, your engagement, your commitment to learning, and this is what makes our community strong. Together, we are building an understanding, connection, and hope. Our next session will take place on May 5th when we will hear from Dr. Gudrun Schleiermacher, who will speak about liquid biopsy, its role in neuroblastoma, and how it may help improve outcomes for children. We hope you'll continue to join us, and we'll bring more voices from across the global neuroblastoma community to share the knowledge and updates. Until next time, please take care, stay informed, and remember, together we can change the future of children with neuroblastoma. Thank you so much.